Good afternoon, everyone. We'll call this meeting of Health and Human Services Subcommittee to order. At this time, it looks like we have 3 agency report outs, and we will be beginning with DHS Child Support Administration, then going to Department of Aging, and then going to MDH Health Regulatory Commissions. At this time, we'll bring up Ms. Naomi Camaro to give out the report for DHS Child Support Administration.
Thank you, Mr. Chairman. I'm going to share my screen. All right, my name is Naomi Camaro. I'm here with the Department of Legislative Services presenting the fiscal 24 allowance for DHS Child Support Administration. The fiscal 24 allowance grows by 2.4% to $104.9 million. And that total is broken up by the pie chart you can see in Exhibit 1. A majority of the budget is allocated to personnel, and most of that is going to the public-facing personnel in the local departments for social services. There's also 8% of the budget allocated to the Baltimore City privatization contract. Baltimore City is unique in that DHS contracts with a private vendor to provision those services. Exhibit 2 on pages 3 and 4 shows the line item changes between the working appropriation and the proposed budget. And I'll just point out some of the larger changes. On page 4, there's a reduction in expenses for information and referral services through the state call center, as well as a reduction in state disbursement unit expenses due to realigning with pre-COVID-19 levels of service. There's an increase of over $1 million for supplemental IT support for the child support management system. In personnel, I wanted to point out that CSA has a relatively high vacancy rate of 13.11% as of December 31st, 2022, and had 85.5 vacant positions. 61 of those positions were child support specialist roles, which were impacted by DHS's department-wide compensation plan in November of 2022. And then further discussion of DHS's vacancies is included in the DHS administration budget analysis, which was presented a couple weeks ago. So the first issue that I wanted to discuss today is related to child support performance. The U.S. Department of Health and Human Services sets goals for state child support agencies in 5 areas. I'm going to discuss 4 of these 5 today. First is the establishment of child support orders, the establishment of paternity, collections on support due, and then collections on arrears. In Exhibit 3 on page 7, you can see the federal fiscal 21 and federal fiscal 22 performance against these measures, as well as the goals set by HHS. In federal fiscal 22, DHS met 2 out of the 4 federal incentive goals in cases with support orders and current support due. As I mentioned earlier, pardon me, most of the jurisdictions operate the local Department of Social Services through DHS, but Baltimore City contracts with a private vendor, and so they have slightly different requirements. So Exhibit 5 on page 9 shows the minimum service levels, those red diamonds that the vendor has to meet according to their contract, or DHS could levy a penalty against them. And so in federal fiscal 22, Baltimore City met 3 out of the 4 minimum service goals. DHS has decided not to levy a penalty against them because of service interruptions and challenges due to the COVID-19 pandemic. I'm going to turn to another performance measure. Further information about the local jurisdiction performance can be found in DHS's response to the JCR report. So collections on current support due and overdue support is also measured by DHS. This chart shows the total collections between fiscal 2018 and fiscal 22. And I wanted to point out a rise in collections in fiscal 2020. The total collected was $583 million, and that was boosted primarily due to a rise in collection in arrears, which is represented by the red line. DHS was able to intercept some of the earliest federal stimulus payments early on in the pandemic, and so that helped boost the amount of money they were able to collect. I'll turn now to the new data system. This is just a brief update. The child support management system was decommissioned in September of 2022, and the new system is now operating on the MD Think platform. Exhibit 8 on page 13 just shows the number of staff at each local jurisdiction who are trained and yet to be trained in the new system as of June 30th, 2022, and DLS asked for an update from DHS on what staff still need to be onboarded, which they provided in their written testimony. So I'll close with the DLS recommendation for the committee, which is to adopt a narrative requesting child support performance reports, including information on how the new data management system is supporting this work. That concludes my presentation.
And thank you, Ms. Camaro. At this time, I'll bring up Secretary Lopez and his team. Ms. Secretary Lopez, it does feel good to take the acting away.
It certainly does, sir. Very good afternoon, Senator McCray and honorable members of the committee. My name is Rafael Lopez, and I am the Secretary of the Department of Human Services. Thank you for the opportunity to present to you the department's Child Support Administration budget for fiscal year 2024. Joining me at the table are all the way to my left, Carnita Wright, our Principal Deputy Secretary. I'm on to my right, to my left, there you go. And to my immediate left is Kevin Geisweit, Executive Director of the Child Support Administration. And to my right, Stafford Chimpungu, who is our Chief Financial Officer. In addition, I'm joined behind me by a posse of DHS folks, including Daniel Waite, Deputy Secretary of Operations, Jarnice Johnson, the Deputy Executive for Programs for Child Support Administration, Debbie Marini, Director of Frederick County Department of Social Services, Susan Coppage, Director of Queen Anne's County Department of Social Services, and Jen Dubosc, Director of the Dorchester County Department of Social Services. As you've been seeing at a variety of department hearings, we want to make sure we're intentional about including our MASD colleagues, so we have a variety of diverse voices from our jurisdictions across the state. Before diving in, I also want to take a moment to thank Naomi Kumuro for her comprehensive analysis of our department's budget. Now on to the meat of the budget hearing, which is obviously we've shared with you the written testimony, and we'll lift up a couple of items as we dive in. Top of mind for me, obviously as a new member of the team, are the over 1 million Marylanders that we serve each year, and the more than 5,000 team members who provide those services. So we're grateful to all of them. The Child Support Administration strives to make certain that children grow up receiving support from their parents, and that the family is able to maintain economic independence. This requires a focus on the whole family. Maryland's child support program cannot be siloed or stand alone. Rather, it must be integrated into our human services programs and proactively engage with child welfare and family investment programs to ensure families are supported to thrive. But we cannot do this alone. We look forward to working with each of you, the General Assembly, the federal government, and the Maryland Judiciary to ensure Maryland's child support policies and practices support all Marylanders, but most importantly, what is best for Maryland's children. CSA provides comprehensive support services to approximately 189,000 children across the state. Over the last, CSA has collected and distributed $511 million to these families last fiscal year. Specifically in federal fiscal year 2021, Maryland ranked above the national average in 3 key federal child support performance measures. 1, in cases paying arrears, where we were 73.16% or 10th in the nation. Current support collected at 68.7%, and 4D paternity establishment at 96.21%. We support non-custodial parents with job training assistance. Specifically, our programs are offered in all 24 of Maryland's jurisdictions in partnership with the Family Investment Administration. Through September 30th of last fall, there have been 11,618 non-custodial parents enrolled in non-custodial employment programs outside of Baltimore City, representing over 26,000 cases. And just to give you an example of those, of these, over 16,000 cases had a payment distribution after enrollment in the program totaling distributions of 217 million. And just to highlight a couple of those programs across your jurisdictions, these programs include those like Winning Fathers program in Baltimore County, or Parents as Partners program from Caroline, Job Network in Baltimore County, or CAPE program, which is the County Alliance program for Employment in Washington County, or Networks in Somerset, Wicomico, and Worcester counties. With Baltimore City specifically, the primary program there is a Step Up program, which stands for Supporting, Training, and Employing Parents. And during federal fiscal year 2022, there were 207 non-custodial parents enrolled in Step Up. This represents 374 active cases, of which 53.2% had a payment distributed and 82 cases received multiple payments. These are all steps in the right direction to include multiple partners and making sure children have their needs met. Now I'd like to turn your attention to the recommended actions that have been shared with you by our analyst. We concur with the one recommended action, which is to provide 3 reports on child support performance. Now I'll turn our attention to the issues. Issue number 1 on page 8 of your analysis asks DHS to discuss whether a penalty was assessed for the missed minimum required service level. We want to share with you that DHS chose last year not to impose a penalty because the vendor improved their performance overall. It was determined that the failure to meet the performance by a few percentage points was due to factors outside of the vendor's direct control, and that the pandemic forced the courts to limit scheduling court cases that directly impacted vendor performance. In addition, conversion to the new child support management system within MD Think, as has been brought up, also affected the performance, ranging from data conversion to training, as well as system stabilization challenges. Next, I'll turn our attention to issue number 2, which is on page 12 of your report. This asks us to adopt committee narrative, or for you to adopt committee narrative, requesting periodic reports on CSA's performance against the federal incentive objectives and utilization of the new child support management system. We concur with this recommendation and will provide those reports against the federal incentives. And as we strengthen the muscle around this new module at MD Think, we think that'll be even easier to do with greater timeliness. Now we'll turn to issue number 3 on page 12 of your report, which is asking us to comment on the number of staff that have been trained and are awaiting training as of January 1st of this year. Specifically, as of January 1st of this year, 766 staff have been trained, and we have provided details of staff by child support jurisdiction in our response for your convenience. Now I'd like to highlight an issue that has come to our attention in the spirit of candor and transparency, which is that over the course of the last couple of weeks, we've come to learn that there is an error within the Child Support Administration related to data and an incorrect tax intercept error at the federal and some at the state level. So I want to walk you through what we've discovered, walk you through what we're doing about it, and walk you through how we're moving forward. So I was briefed last Wednesday, March 1st, by my colleague, Kevin Geisweit, that as a result of responding to calls and email outreach, we learned that some Marylanders were experiencing what we call a tax intercept of their expected federal and state income tax returns. In other words, their tax returns were incorrectly being withheld because of an error on the part of the Department of Human Services. With your permission, I'd like to walk you through the 2 components of this challenge and share that we are working diligently to resolve these issues at the federal and state level. So first, I'll address the federal issue. At the federal level, the Child Support Administration certifies obligors, which is a word I just don't like, I'll tell that to Kevin, who owe past due child support for federal tax intercept with the Federal Office of Child Support Enforcement. They are our colleague agency at the federal government. This file is then processed and shared with the U.S. Department of Treasury and Internal Revenue Service to intercept federal tax refunds up to the amount of the past due support owed and certified, and they remit it to the Child Support Administration. The issue is that some obligors began calling approximately 2 weeks ago to report receiving notice from the U.S. Treasury that their federal tax refund was intercepted by CSA for past due support, which they do not owe. These obligors were incorrectly decertified by the new Child Support Management System, or CSMS, through records in both CSMS and my MD Think consumer portal, which indicated no past due support was owed. The Federal Office of Child Support Enforcement indicates their records, as reported by Maryland, include these individuals as owing past due support. While not completely verified at this moment, the error may have occurred during decommissioning of our legacy child support enforcement system as DHS transitioned to the new system on MD-Think. While the total number of Marylanders that may be impacted is unknown at this time, our team is working on estimates to better understand the scale of the error across the state. I can definitively share that as of Friday of last week, we have already issued refunds totaling $114,626.81 to nearly 100 non-custodial parents whose federal tax refund was intercepted in error. I want to walk you through the actions we've taken to date since we've learned of this error. We've done 4 specific things. We've confirmed with OCSC at the federal level that non-custodial parents are certified for past due support, while CSMS records reflect otherwise. Number 2, we are proactively assisting customers as calls are received notifying us that they were involved in this. Number 3, we are processing refunds immediately via CSMS as the funds are received from the US Treasury, as I just articulated for those 100 non-custodial parents. And number 4, we are proactively paying for any fees customers may have incurred as a result of this error within our existing budget. Moving forward, we are also working with MD-Think and taking 3 courses of action. We have opened up an initial investigation to determine how non-custodial parents were certified to OCSE. Number 2, we confirmed with CSMS that they had to certify the non-custodial parents to the federal government. And 3, we are conducting a reconciliation with the federal government Office of Child Support Enforcement to verify and ensure that these records match moving forward, that we decertify any obligors who do not owe past due support, so tax refunds are not intercepted going forward. And finally, that we identify impacted non-custodial parents to CSA for any communication needing to notify them. So that's the context of what we've been doing at the federal level. Now I want to walk you through what's happening at the state level. Fortunately, it's actually a smaller universe, but we want to be very clear about what we're doing. So like the example I just gave for the federal government, some individuals began calling within the last week to report receiving notice that their state tax refund was intercepted by CSA for past due support, even though they do not have children or have ever had a child support order. While not yet completely verified, the issue here is likely the result of incorrect linking of customers based on master data management and or system file matching errors. At this time, there are only 3 known issues reported to us within the state of Maryland under this particular matter. And of those, only 1 was an actual error impacting a state tax intercept. As we continue to work on resolving this matter, we're learning that the state level issues typically result from data entry issues, which are easily identified and resolved. DHS and the Comptroller's Office are working closely in partnership to reconcile data and address a relatively small number of cases. And I wanted to say for the record that this error we are encountering at the state level is ours. It is the Department of Human Services. It is not the Office of the Comptroller, and I want to say that loud and clear. Comptroller Lehrman and her team have been very proactive with us and willing to dive in with our team to figure this out and to solve it. And we're grateful for her and their patience and their partnership. So again, similar, I want to walk you through the actions we've taken to correct this error. Number 1, we verified the individuals are known customers to other administrations, not just CSA. 2, we reported the information to MD-Think for additional research. 3, we are assisting customers as they call into us for help. 4, we are processing refunds immediately via CSMS as the funds are received from the Comptroller's Office. 5, any fees that may occur to the customer as a result of this error will be paid by CSA's existing budget. And finally, number 6, we continue to meet with the Comptroller's Office to plan a reconciliation of the records between our programs to ensure there are no additional errors. And as I said earlier, they've been extraordinarily cooperative and working with us as a team. On the MD-Think side, we have launched an internal investigation to better understand why this happened and how we can avoid it from happening again in the future. We know that you care deeply about making sure your constituents get the help they need when they need it. And we apologize for the inconvenience of this error may be causing you and your constituents. We stand ready to help you resolve these issues and know that we'll get to the bottom of this matter as quickly as possible. With that said, this concludes our testimony and we'd be happy to answer any of your questions. Thank you.
Thank you, Mr. Secretary. I work my way backwards. Could you define like return immediately?
Sure. I'll give you what I know, and then Kevin, if you want to go into more detail. When it came to our attention through Kevin and his team, it took us a few days to return it. We have to wait for state treasury funds to be reallocated to us or the comptroller. In this case, was only one. And I want to say it was under 5 days. Please correct me if I'm wrong.
5 to 7.
5 to 7.
No, that's perfect.
That's as immediate as state government's going to get right now. We let me tell you, brother, we want to make it faster. So
I was
we know
gonna
it.
say 2 weeks. 5 to 7 is what wasn't what I was thinking.
The team knows I want to do it faster, but we, one step at a time.
Yes, sir. The second one is if your team would be able to get back with Ms. Camaro in reference to the 8 vacancies that have been longer than a year, in reference to what was the classifications and like what's the plan to fill those 8 vacancies.
Absolutely.
The second one is, could you give a status update in reference to the contract for Baltimore City? Inside the report, it says March 2023, the RFP will be put out on the streets, and just wanted to understand
Absolutely.
if that has taken place. And then the last one is, in your testimony, when you talked about the child support management system and those folks that have been trained, you used the word offered. So it said offered training. Couldn't understand if this was voluntary or if this was mandatory from the word offered.
Let me break it up into 2 components.
Yes, sir.
I'm going to first ask Kevin to walk you through the RFP process. While I have read the RFP, I don't know all the details because it was launched prior to my arrival. So we'll do that. And then I'll get into the training. And actually, Kevin, if you don't mind commenting on how that was launched, and I'll talk about what I intend to do moving forward with all training across the department. Thank you.
All right, thank you for your question. The first one, in terms of the RFP, we've been working over the last year to get that ready to go. It is right now in its final stages with our attorney to review, and then it will be going out to the Office of State Procurement with the goal to get it out by the end of this month. In terms of the training, we did offer the training to all of our staff across the state. To our knowledge, it was mandatory to the degree that we wanted to attend it. We offered multiple opportunities, including refresher opportunities. So everyone should have had it by this point. Where I can't guarantee is if someone left service, and didn't get the training or something before that time. But the training has been available and to continue to be available through various online resources, as well as refresher training is available to reschedule and offer as we have new employees joining as well.
Thank you, Senator Zucker.
Thank you very much, Mr. Chair. Mr. Secretary, thank you for, not many times in government does someone actually admit when something's wrong and then what you're trying to do to fix it. Just, I guess, because you're still getting set up with everything, do you think it makes sense in the next month or so just to do with all the new software and databases that we've created over the years with MD Think? Do you think it makes sense just to have someone do another kind of once over on it just to make sure that this isn't an issue somewhere else?
Absolutely. And I'll give you an example of what we're actually doing. In my first conversation with the Maryland Association of Social Service Directors, one of the main themes that they made clear to me was their concern over the day-to-day implementation of MD Think. It doesn't mean that everything is broken or bad. It means that some of the things are still a struggle. As we are working on change management to make sure all of our staff understand across the state how this is playing out, there are both technical errors as well as human errors. And so one of the things that we agreed to do with MASTI as well as our MD Think partners is to launch a first ever retreat across the state. That's happening tomorrow. We are convening all 24 jurisdictions with teams from all over the state that range from frontline staff who use MD Think every day to support a client or customer walking in the door to people who are not at all doing that. The purpose behind that is to build MD Think 2.0. There are some system or technical issues that are still a challenge for our staff. We want to own those technical errors, and we also want to own the change management process that leads to Senator McCrae's question about ongoing training and development. This particular module, I think, went live November 1st, if I'm not mistaken, or September. So in terms of state government, that's not a long time ago. And to expect everyone across the state to be using it the same way and expect the same results, we're not quite there yet. So we, rather than approach it from a negative perspective, we're approaching it from what does 2.0 look like? How do we want our staff to experience it on the ground? How do we want to engage with our clients, both in the public facing portal and when we need to extract reports so that we could be much more seamless about how we're approaching this work? So that's an example of how we're kicking off a new era and engaging between bridging the technical and the operational with the way in which our staff engage across the state. And any of you are welcome to come to the retreat if you'd like to.
Senator Hedelman.
Thank you very much, Mr. Chairman. I'd like to echo my colleagues' remarks. It is refreshing to have a heads up about a mistake and to own it. And so I appreciate that. And the transparency, and just wonder, I mean, I have not heard about this from my office or any constituents who have reached out to us to my knowledge. But if, I guess it would be great if you could check back in with the subcommittee to let us know how widespread the problem is, if you find that it is much beyond the 100 people that you have already identified.
Thank you, Senator. So two things on that point. One, if any of you individually need to follow up with assistance, Rachel Sledge is our Director of Government Affairs. She's obviously a great liaison for you. She knows how to connect any of you to any help you need for constituents, number one. Number two, we have the constituent call center. So I know you know that number as well. And number three, Kevin, we're trying to track diligently where this is happening across the state. As of last week, we testified before the House, we had less information than we have today for you in the Senate, because we're trying to diligently figure out what's happening. So we, fingers crossed, it'll be hundreds, not thousands across the state. And then we'll easily come back to you with a pattern of trends analysis, which is where did it happen? And hope we can work on the tech side as well as the staffing side to answer it.
Appreciate it. Thank
Sure.
you. Thank you, Mr. Chairman.
Thank you, Senator Haldeman. Thank you again,
Certainly.
Mr. Secretary. I ain't gonna keep giving you all the accolades. It is just good to see folks take extreme ownership and just the path to move forward. So thank you and your team.
Absolutely.
In reference to that. And
Team effort.
thank you, Ms. Camaro, for the excellent job that you do in reference to the analysis. Colleagues, we do have one person that's given public testimony at this moment. I would like to offer up the floor to Ms. Anissa Alexander. The floor is yours, Ms. Alexander.
Good afternoon. My name is Anissa Alexander, and I have been with the Prince George's County Office of Child Support for 20 years. I am here speaking on behalf of the hardworking staff that make up the entire state's Office of Child Support. For the last 8 years, child support workers have suffered from short staffing and a lack of resources to ensure financial support for many children across the state, which includes the repayment of monies due to the state for cash assistance. Our caseloads are overwhelming and work goals are not being met. And all the while, management provides threats of disciplinary actions against us. Recently, we transitioned to a new computer system created within the department's MD Think program. And daily, and that includes today even, we are experiencing system delays, poor functionality, and payment issues. Some seasoned staff like myself are working longer hours while others have submitted their retirement paperwork. And with each retirement, that pin is removed by the Department of Budget and Management, resulting in a permanent employee position that's missing now. New staff are easily frustrated and are dissatisfied with the pay, many of which leave the agency within the first 6 months. Each year we come before you asking for help, and while we greatly appreciate the support and empathy, we are in dire, dire need of additional staffing, better pay, and better resources. With your help, not only will the agency improve, the state repayments will increase, but more importantly, more children from single-parent homes will finally get that support, the financial support that they need. Thank you for your time, and thank you in advance for your assistance.
Ms. Alexander, just wanted to say thank you as a son of a retired state worker. I think I say it on behalf of all my colleagues. Just thank you for your leadership. Thank you for your service to our great state of Maryland. Colleagues, that ends our hearings for the Child Support Administration. We're going to move and deviate from the agenda a little bit and go to MDH Health Regulatory Commissions. And at this time, I'd like to bring up Ms. Ann Wagner.
Thank you, Mr. Chairman, members of the committee. I'll just set up real quick and share my screen so everyone can see the analysis. today I'm presenting the operating budget analysis for the MDH Health Regulatory Commissions. These are 3 independent offices within the department, including the Maryland Healthcare Commission, the Health Services Cost Review Commission, or HSCRC, the Community Health Resources Commission, or CHRC, and the Prescription Drug Affordability Board. The fiscal 24 allowance provides $300 million almost entirely in special funds for these agencies. The analysis breaks out the uncompensated care fund managed by HSCRC as the largest source of special funds. That fund is distributed among hospitals to account for the care that hospitals provide that they do not receive compensation for. On the next page, there's one item related to fiscal 23 on the Maryland Healthcare Commission. In last year's JCR, the budget committees requested that MHCC conduct an independent analysis of the behavioral health crisis response system, including contracting with a vendor for a needs assessment and convening a work group. MHCC has not procured the vendor or met with the work group, so the department is asked to explain why there hasn't been progress on these requested activities. Moving to the fiscal 24 allowance, Exhibit 1 provides an overview of spending. After accounting for the uncompensated care fund, the next 2 largest sections of this budget are grant programs administered by the CHRC. That includes the Consortium on Coordinated Community Supports and the Pathways to Health Equity, or Health Equity Resource Communities funding. Exhibit 2 breaks out spending for the remaining 30% of the budget. About half of that funding supports administrative costs across the 4 units and the Maryland Primary Care Program. The other half supports additional grants and operating expenses for CRISP, which is the state's designated health information exchange. Exhibit 3 provides a list of changes between the working appropriation and the allowance, totaling a $36.5 million increase. I'm going to jump ahead to page 7. Which describes the largest change, which is a $35 million increase for the Consortium on Coordinated Community Supports. This program was created in the Blueprint for Maryland's Future to meet student behavioral health needs through community supports partnerships and best practices for behavioral health and wraparound services. Since August of 2022, the consortium has been meeting regularly, and the first annual report was issued in December. The consortium is also charged with implementing a grant program, so that's the main driver of the $35 million increase, as the mandated funding increases from $50 million to $85 million. A 2022 bill altered the program slightly to have higher mandated funding levels starting in fiscal 24, and to provide 2 additional positions to staff the consortium, and those are included in the allowance. The department is asked to provide an update on issuing a call for proposals and distributing the consortium grants in fiscal 23. Another grant program I'd like to highlight is CHRC's annual operating grants for safety net and community health programs. These grants and CHRC's administrative expenses for this grant program are typically funded at about $8 million each year. The BRFA of 2021 changed the fund source for these grants by diverting funds from the Health Benefit Exchange's reinsurance fund in fiscal 23 and 24 only. And so the analysis notes that the funding source for these operating grants is set to end after fiscal 24, after which the CHRC would need to compete for general funds to continue these grants. So then moving on to the key observations section, the first item discusses how the COVID-19 pandemic has affected Maryland hospitals' financial stability. Under Maryland's unique all-payer hospital rate setting system, the HSCRC is charged with setting hospital rates. And since 2014, the rate structure shifted to setting population-based revenues, in which HSCRC sets a global budget for each hospital as a revenue target, and hospitals then charge rates that add up to that target. In a response to last year's JCR, HSCRC generally found that this financing model provided Maryland hospitals with much more financial stability during the pandemic than hospitals in other states were experiencing. Exhibit 4 illustrates the impact COVID had on hospital admissions. You can see that they fell sharply in April 2020 due to the pause on elective procedures and lower demand for hospital services. And while revenues also fell sharply in that month, hospitals were able to increase their rates, and that brought hospital revenues back to pre-pandemic levels and even above that level. So HSCRC described 2 different costs, 2 potential costs for hospitals due to the pandemic. The first one is the cost of treating COVID patients. However, HSCRC sets rates in such a way that hospitals generally received enough to cover those costs as long as they didn't reach their global budget targets. And then additionally, since all non-COVID admissions were down during this time, hospitals didn't really run into this issue overall and weren't meeting their global budget targets. The other potential cost was more overhead needed to purchase PPE, prepare for surges, and deal with workforce shortages. And again, these costs were offset by the drop in other non-COVID admissions. And then considering the uncertainty during this period, the federal government and HSCRC did make aid available to hospitals. And so the first item at the federal level was mostly coming through over $1.3 billion in financial assistance through the Provider Relief Fund. To account for this assistance and revenue that hospitals were receiving, HSCRC offset global budget targets by the funding distributed through the Provider Relief Fund. A few other actions that HSCRC took at this time were to, allow hospitals to increase rates by a higher percentage than is normally permitted, and then allowing hospitals to carry forward a portion of their global budget revenue that they did not charge up to and move that into the next year. Exhibit 5 shows how these 3 actions made up the difference in hospitals' global budget revenue shortfalls, with the undercharge carry forward and then the corridor relief increasing hospital rates for all payers, and the Provider Relief Fund offset actually is decreasing hospital rates. Exhibit 6 shows the relative hospital operating margins before and during the pandemic, showing that hospitals maintained their financial stability under the system and then even grew their operating margins in fiscal 21. So the department is asked to provide an update on fiscal 22 hospital operating margins, and to comment on whether hospitals have continued to experience overall stability. And then lastly, there have also been supports provided to hospitals totaling $75 million, which are provided mostly for workforce supports in fiscal 23. So HSCRC is also asked if that, the department is also asked if that financial assistance will be taken into account in future rate setting. So then moving on to the second key observation, this discussion relates to the total cost of care model, which is a 10-year agreement with the federal government to improve population health, improve care outcomes, and control the total cost of care for Medicaid or Medicare beneficiaries. Under the agreement, Maryland must meet certain Medicare savings targets. And I will say all other targets in the agreement are outlined in Appendix 2, but I'll be focusing on the cost-related targets. So turning to Exhibit 7, Maryland must meet certain Medicare savings targets that increase each year. In calendar 22, Maryland's Medicare costs have increased substantially more than the national costs and are not expected to meet the Medicare savings targets. That's shown with the dotted line, getting to about 80 million expected in calendar 22. As a result, HSCRC is taking a few proactive steps to try to reduce Medicare costs. These are outlined on page 16. The first item, reducing all payer hospital rates, that did take effect in January of this year. The second and third items both have already received federal approval from CMMI. The first discounts Medicare payments. The second is increasing the public payer differential to 1%. So this is what we had discussed in the Medicaid analysis as being an action that would create Medicare savings, but would also create Medicaid savings. And that's expected to be implemented in April of this year. And then the final item is reducing the Medicaid deficit assessment. The allowance as introduced does include this action, and it includes both contingent funding of 50 million in general funds and a contingent reduction of 50 million in special funds. And so that's in the allowance for your consideration. Moving on to another program within the total cost of care model, which is the Maryland Primary Care Program. Under this program, primary care providers are paid incentives to deliver advanced primary care services. These incentive payments are supported with federal funds, but they count against Maryland's Medicare spending totals. And so the past few years, there have been reports requested to evaluate this program and to provide the cost effectiveness of this program over the years. Exhibit 8 shows that there has been a net increase in costs so far from this program. And so as a result, MDH is asked to comment on potential changes to the program to make it more cost effective. And DLS is recommending continued monitoring of this program through narrative that would request an evaluation of the Maryland Primary Care Program. Part of these evaluations also ask about the racial diversity of the program, both in terms of the participants and the providers who are participating. This exhibit shows the most recent results, showing that the participants in this program are slightly less racially diverse than the state's Medicare beneficiary population. I will also note that they provided the information for the diversity of providers in the program, but that was an optional report from the providers, and only 36% of providers reported the data requested. But the department did note in that report that diversity among physicians is a statewide and a national issue. And so that was provided in that report. The last thing I'll discuss is the Regional Partnership Catalyst Program. So part of the total cost of care model also tries to improve population health measures. Maryland has received approval for setting goals related to preventing diabetes, mitigating opioid overdose deaths, and improving maternal and child health. And so the Regional Partnership Catalyst Program also works on these goals and provides about $225 million over 5 years as an investment to improve the outcomes on these goals. Specifically on the maternal and child health measure of this, the BRFA of 2021 allowed for HSCRC to provide some of the funding to MDH's Prevention and Health Promotion Administration and Medicaid to provide these funds to programs not managed by those departments, but to provide through those programs to focus on maternal and child health improvement. And so the analysis notes that there's $18 million in special funds included in the allowance when you include the $10 million budgeted under HSCRC and then $8 million budgeted under Medicaid and Prevention and Health Promotion Administration. And so the department's asked to comment on how it will spend the budgeted funds in fiscal 24, particularly the $10 million that's budgeted in HSCRC. And with that, I will conclude my presentation. I'm happy to answer any questions.
And thank you, Ms. Wagner. And seeing no questions at the moment, I'd like to bring up Secretary Herrera Scott and her team to give out the report for MDH Health Regulatory Commissions.
Good afternoon, Chairman McCray, members of the subcommittee, Laura Herrera Scott. Like you said, for Secretary Lopez, Secretary Herrera Scott, officially sworn in. I'm here today with Katie Wunderlich, Executive Director of the Health Services Cost Review Commission, Ben Steffen, Executive Director of the Healthcare Commission, Mark Luckner, Executive Director of the Community Health Resource Commission, and I unfortunately, oh, sorry about that.
Andy York is a prescription drug.
I'm sorry. Andy York, prescription drug affordability. Additionally, they have commission staff behind them and are available for questions. I want to thank Ms. Wagner, as always, for your analysis and the rest of your team. And certainly thank Ben, Katie, and Mark and Andy and their teams for their steadfast work over the past year. Happy to answer any questions of me you have at this time, but if there are none, I'm going to actually turn it over to Ben to start, then we'll go to Katie and down the line.
Thank you very much, Mr. Chairman, member of the committee. My name is Ben Steffen. With me today, along with is Richard Proctor, Chief Operating Officer, and Tracy DeShields, Director for External Affairs and Program Development. The Maryland Healthcare Commission is a commission that has 4 key functions: health facility planning, the promotion and oversight of the diffusion of health information technology in the state, the development of quality and cost measures that are displayed on a variety of public-facing websites, And lastly, responsibility for reporting on a broad range of public policy issues, many of which are requested by the General Assembly, and issues in which we use our unique data and information resources to provide insight to a broad array of healthcare policymakers here in the state. I have a rather extensive slide deck, which is included in your materials. I also, I'm not going to go through that directly, but what I am going to comment on is the analyst, Ms. Wagner's questions about the behavioral health crisis response analysis. Her work was comprehensive and very clear and complete. I want to thank her for that work. With regard to the behavioral response, crisis response initiative, we didn't complete the assessment, but it's not because we didn't do anything. Beginning in July of last year, we began meeting with the Behavioral Health Administration and Medicaid to determine what had been done, what was being done, and what was planned. We reached the conclusion that a behavioral health response assessment did not really align with where the respective agencies were in terms of rolling out very expansive programs to address behavioral health needs. We actually came upon a rather unique experience in meeting with a consultant that potentially we saw as a bidder. This was work before any RFP had been developed, and were advised that this particular study triggered by a RFP probably wouldn't be needed at this time. Based on that information, we have continued to participate in a host of MDH work groups, including the Secretary's bed registry group that has been meeting over the interim to look at addressing that particular challenge. We have also, for the first time, worked with the department to expand access to residential treatment centers here in Maryland, and SCON was awarded recently to allow for a small expansion on that particular type of facilities. So as we look upon this particular issue, I have two recommendations that may be helpful. One is that instead of a broad-based behavioral health risk assessment, perhaps we would be better used to be convening private payers in how they are responding to the behavioral health crises. Historically, commercial insurers have responded to behavioral health challenges by engaging their own enrollees directly in the behavioral health system. I think as we roll out this broader initiative, engaging the commercial payers more directly would be valuable. And secondly, as these new programs roll out, we may be valuable in providing an evaluation once the program has been more fully established. There's a methodology now known as rapid cycle assessment or evaluation done typically by the federal government through CMS. If you so directed, we would use a similar approach to gather information on the success of these behavioral health programs. We are in the midst of releasing our 2023 through 2026 set of strategic priorities, which will have an increased focus on health equity. And I look forward to providing that document to you in the following week as it is completed. I'll stop here and happy at the conclusion of our presentations to answer any questions.
Thank you, Mr. Chairman and members of the committee. My name is Katie Wunderlich, and I'm the Executive Director of the Health Services Cost Review Commission. I want to thank Ms. Wagner for her comprehensive analysis of our commissions and for highlighting the good work that's underway. I also want to recognize my colleagues here with me today, Xavier Colo, Megan Renfrew, Mark Hoffman, and Paul Katz, all of whom helped to contribute to our response responses and to our work. So I want to thank them as well. We have submitted some written responses to the issues raised, but Mr. Chairman, if it's okay, I'd like to just take a minute to go through what we're doing with the model and then reflect and answer some of Ms. Wagner's specific concerns. So as you know, the Health Services Cost Review Commission is an independent state agency. We are primarily responsible for regulating the quality and cost of hospital services to ensure that all Marylanders have access to high value care. That is our primary responsibility, is to establish rates for regulated hospital services. So that means services that happen at acute care hospitals on the inpatient side, outpatient in the emergency department, and other outpatient services that happen on a hospital campus. We also play an important role in managing the state's total cost of care model. And as the model has evolved over the years from a hospital-based model to a total cost of care model, our work and our purview has expanded to look at coordinating cost and quality targets for not just hospital services, but for non-hospital services as well. We are really proud of the model and the work that is done to support the model in the state. It provides a number of benefits to Marylanders. Just like to highlight a few at the outset. First and foremost, it does keep the growth of healthcare costs contained. So we've been able to contain the growth of healthcare costs below the state gross, the gross state product. So as the economy has grown, we have tried to keep healthcare costs, hospital costs below that trajectory. We also, the model allows the state to invest in statewide population health goals, including diabetes, opioid and behavioral health, and maternal and child health. As Ms. Wagner mentioned, we dedicate a significant amount of time and resources to those statewide goals. And it's an enormous benefit that we're able to harness across the state to focus our efforts to reduce those disparities. We've also, the model also prioritizes health equity. We are the first state in the nation to include a quality measure in a hospital pay for performance program that's focused on disparities. This is one of the really unique and important benefits that we are able to provide here in Maryland. We're able to tailor our quality programs at hospitals specifically to our population. And so we added, first in the nation to add a health disparity measure within hospital quality pay for performance program. We're also in the process of adding a population health measure. So these are all really unique flexibilities that the model provides to Maryland and to Maryland hospitals. We're also proud of the significant involvement of primary care and specialty care physicians in the model. As Ms. Wagner mentioned, there is a significant MD-PCP program, which is a key component of the model. It connects Marylanders with advanced primary care. The program is being developed and is in a really great, adds a lot of value to Marylanders. With respect to financial support and stability, the model provides significant long-term stability for hospitals under our global budget revenue structure. This is a population-based reimbursement system that has moved hospitals away from a volume reimbursement system towards a value-based and outcomes-based budget. And this has been especially important through COVID, as volume volatility has fluctuated during COVID. The GBR also provides significant stability for rural hospitals or hospitals that see a declining number of inpatient stays. It's a significant provides a significant stability to those rural hospitals. As Ms. Wagner mentioned, we did act quickly throughout COVID to make sure the reimbursement and the resources available to hospitals were available so that hospitals could tailor their approaches and care for COVID-19 patients. The model also provides significant support through uncompensated care that allows providers to share the burden of uncompensated care equitably across the state. It's an important equity component in the model. As I mentioned on population health, we're really proud of the work that we're doing to advance population health priorities in concert with the Department of Health and our other state agencies. We have funded regional partnerships across the state that focus on diabetes prevention and management. behavioral health and opioid overdose management, crisis services, and others. And so these programs require hospitals to collaborate with a broad coalition of community partners. And this is really a way that we are able to not only encourage hospitals to work together, but for hospitals to work with their community providers to deliver care, high quality care to Marylanders. Ms. Wagner also noted the change in our total cost of care performance. One of our financial goals is to accrue an annual savings of $300 million in annual Medicare total cost of care savings by year 5, which is 2023. We have dipped below in calendar year 22. Our savings rate has deteriorated, but we've taken proactive steps to address that. And I want to thank Governor Moore for including in the BRFA the one-time reduction to the deficit assessment. But we've taken other all-payer actions and Medicare specific actions to ensure successful completion of this model that we are all invested in. Just to turn to the issues now that Ms. Wagner raised in the analysis, first around hospital margins through COVID and beyond. We've included in the packet for you some a lot of information. I'll hit at a high level. The information that you have in your packet, if you remember, the final audited data is through fiscal year 22. So hospitals submit audited data for the fiscal year for fiscal year 22 that has been submitted. So everything that you see for fiscal year 23 is unaudited year to date. We have seen, so for fiscal year 22, the latest data that is audited, the regulated margins for hospitals sat at about 6.5% on a statewide average. So that's for all of the regulated hospital services, inpatient services, emergency department, outpatient services that occur on a hospital facility grounds. When you layer on the unregulated expenses, the total operating margin deteriorates significantly. So you'll see in fiscal 22, there was a statewide average of 0.8%. So mostly that is due to physician subsidies and investments that incur losses that the hospital puts on their books and does bring down their total margin from 6.5% down to just over break even 0.8%. We've also included it not just as a statewide average, but as a median. So you can see that for fiscal year 22, there was a wide variation in hospitals' total operating margin that ranged from as low as negative 5.9% to as high as 4.2%. And this is something that we look at and monitor hospitals' financial viability. We look at it month to month. So we do have that as a metric that we discuss at our monthly commission meetings. Ms. Wagner also asked about the $75 million of grant dollars that hospitals receive for workforce support. We do not plan to offset that $75 million in rates. We did offset the provider relief fund CARES Act dollars, but that was specifically because those PRF funds were meant for to replace lost revenue. So since we regulate hospital revenue, we thought it was prudent to take that into account. The other issue that was raised is on MDPCP. We concur with the analyst's recommendation for another report on MDPCP. It is a significant investment, one that is crucial to developing a coordinated and advanced primary care system, which I think will benefit Marylanders. It's important to note when you think about changes to the primary care program that the primary care program is administered jointly between the MDH Program Management Office and CMMI. And so it is a jointly administered program with final decisions really going through the federal government. And the state has worked with the CMMI on changes to the MDPCP program to continue to progress that program. So we'll definitely be open to additional evolution of the program. And I believe that concludes the issues that were raised specifically for the HSCRC, but as my colleague, Mr. Steffen indicated, I'd be happy to answer any questions at the conclusion of the panel. Thank you.
Good afternoon, Mr. Chairman. Mark Luckner, Community Health Resource Commission. I'm third of four, so you're halfway through this. I'm going to begin my remarks. I'll be very, very brief. And I'm going to begin my remarks with a couple of thank yous. First, I would thank Ms. Wagner for her analysis. We all say that we agree with the analysis. She made an important point about our budget in the out years, which I'm going to talk about in a minute. Second, I want to thank the administration for the allowance for fiscal 24. As Ms. Wagner pointed out, it shows a dramatic increase in our responsibilities of the Community Health Resource Commission due to the fact that we have 2 new programs that we're implementing thanks to the actions taken by this committee. So thanks for the vote of confidence. Those 2 new programs are the Maryland Health Equity Resource Act, which has 9 programs across the state, 3 in Baltimore City, 3 in Prince George's, and 3 in rural areas. Happy to talk with you about that in greater detail. And then the second program, a lot of words, the Maryland Consortium on Coordinated Community Supports. That was part of the Kerwin bill, and we are commission staffs that entity. We serve as the fiscal agent, and in fiscal 23, there's $50 million in it, and in fiscal 24, there's $85 million. And as Ms. Wagner's analysis points out, that's a dramatic increase. And so we're planning to issue the first call for proposals this spring, so that there will be new programming in all of Maryland's jurisdictions in time for the beginning of the next school year. And I'd be happy to answer more questions about that. Turning to the growth and some of the issues that Ms. Wagner pointed out. We have 4, when I came to the commission, we had 3 pins. Now we have a total of 10 pins. We just hired a new CFO. He started, this is his 6th week. Bob Lally is back in our office in 45 Calvert. Great guy, doing a lot of great work for us. We have 2 new positions to recruit for the Health Equity Resource Program, and then 4 for this consortium. And so your committee approved Senate Bill 556 last Friday, as introduced by the chairman, and it will give us independent salary setting authority to fill these key positions. So thank you for that support, really appreciate it. Turning to Ms. Wagner's comment, our commission was created in 2005. I've been here since 2009 to expand access to health services for folks that fall through the cracks. These are low-income folks, uninsured, salt of the earth. That's who we support. And we've been specially funded since we were created by the General Assembly in 2005. Actions taken by the General Assembly in the 2021 BRFA switched our fund source from the Care First funds to the funds managed by the Maryland Health Benefit Exchange. That was for 2 years only, in 23 and 24. And then 25, if no action is taken in this General Assembly, our commission will move, as Ms. Wagner pointed out, to general funds. And that's of major concern for our commission, having been specially funded since our inception. We think that will dramatically deteriorate our ability to act as a nimble steward of public funds. So our 2 requests for this subcommittee are, number 1, please continue the mandated appropriation at $8 million a year, as has occurred since for many, many years. And then second, that we continue to receive special funds. With that, Mr. Chairman, I'd be happy to answer questions at the appropriate time. And thank you again for the support of this committee on the Community Health Resource Commission.
Mr. Chairman, members of the committee, thank you for the opportunity to speak with you today. My name is Andrew York, and I'm the Executive Director of the Maryland Prescription Drug Affordability Board. We are the first in the nation entity or agency created to make prescription drugs more affordable for Marylanders. This is our first fiscal year as an independent agency, so it's a very exciting year for us. And we just wanted to start by thanking Mrs. Wagner for her very thoughtful analysis, thank the administration for their allowance and their support. And then finally, we'd also like to thank the department and specifically the Maryland Healthcare Commission for being wonderful sponsors and partners with us as we've stood up and become an independent agency. I will keep it very short. We support this budget and we are here to answer any questions that you have. Thank you.
Thank you, Senator Hadelman.
I think this is Mr. Luckner, but I'm not sure. The question about the consortium and this, the grant program, is that meant for counties? Is it meant for LEAs? Is it meant for individual schools? Can you shed a little light on exactly what is envisioned there?
Yes, thanks for the question. Happy to have a longer conversation after the hearing, but to answer it directly, the consortium's been meeting for about 6 months. We're chaired by former delegate Dave Rudolph. He's our chair. And we have a great group of other consortium members. We've been meeting for about 6 months. And the superintendent, Chaudhry, and others on our consortium on the staff have talked about having this collective impact model in which we have lead organizations in probably about one per jurisdiction, maybe a few more if it's a larger jurisdiction. It'd be called a hub or a backbone organization. And we think that could be a local behavioral health authority or maybe an LMB, right? And so that's gonna be the first track of the RFP that'll go out this spring. And then the second track will be service oriented. And we'll put out a set of best practices or program interventions we'd like to see in place. And we can envision individual school districts or community behavioral health providers or others applying for these grants. An important point about the funding that we'll make available is that the legislature put in the bill that the funding that goes out cannot supplant or duplicate anything that's already in place. So we have to take meticulous detail to make sure that what the grant proposals we get aren't backfilling cuts that have been made or but in fact result in new programming.
Okay, that's helpful. And when do you anticipate it actually like getting into schools?
We'd like to see as many of the grant resources opening new services or expanding new services in time for the next school semester. And our next consortium meeting will be April 4th. We anticipate the consortium will issue recommendations to our commission, who serves as the fiscal agent. The RFP will go out this spring. And then we'll have before, like this month, April, May, and throughout the summer, we want to have significant public outreach to get the word out about this new programming. And we'd love to have members of the General Assembly give us folks to come talk with in the spring, in the summer, and fall.
Great. I would love to follow up with you. One last thing. Are you anticipating question just flew out of my brain.
Well, a reason for us to get together.
Yeah, I'll follow up with you.
I'd be happy to talk to you again.
Okay, thank you so much.
Seeing no further questions, Madam Secretary, just want to say it is a pleasure to take the acting part away. You know, you're one of my favorites. And just wanted to say thank you all for your leadership and everything that you do for the great state of Maryland. Ms. Wagner, just thank you for the comprehensive report and thank you for everything that you do. Colleagues, we're going to bring it up for our last. I didn't see Ed Casemeyer out here.
Oh, sorry about that, Senator. He's my chair. He's ill today, so that's why he's not here today.
No problem at all. Well, that was the only piece of public testimony. So colleagues, we're going to move on to our last agency report, and we're going to have Ms. Naomi Camaro give out the report for Department of Aging.
Thank you, Mr. Chairman. I'm going to be presenting the fiscal 24 allowance for the Department of Aging. The fiscal 24 allowance, oops, pardon me, grows by a total of 9.6% to $88.8 million. And Exhibit 1 on page 3 shows the breakout of the fiscal 24 allowance. There's 42% of the budget allocated to programs required by the Older Americans Act, and 13.9 million of that is generated from federal stimulus funds to support those programs. Exhibit 2 on pages 4 and 5 show the line item changes. And I wanted to point out that this 9.6% increase is driven primarily by federal funding, federal stimulus funding through the ARPA program, the American Rescue Plan Act, and SRSA funding that's going to be expiring in September 2024 and September 2023, respectively. Skipping to, apologies, page 8. Looking at personnel, as of December 31st, 2022, the department had 10 vacancies for a vacancy rate of 25%, and DLS estimated that the department would have about $804,000 in savings due to holding a higher than budgeted vacancy rate. And we've asked the department to comment on how it plans to use the vacancy savings. On page 9, we started a discussion of waitlists and participation in 3 key programs that received enhancement funding in the federal in the fiscal 2023 working appropriation. Those programs are senior care, which provides financial assistance and case management to seniors living on their own. The Senior Assisted Living Subsidy, or SALS, which provides subsidies for folks who have opted to live in assisted living facilities. And then the Congregate Housing Services Program, which places people in congregate housing and offers some personal assistance. All three of these programs have experienced relatively high wait lists in recent years. And like I said, the fiscal 23 appropriation enhanced their budget by a total of $3 million. In response to the 2022 JCR, the Department of Aging included data on wait lists and participation in these three programs. And this is showing the change in funding between fiscal 2022 and the proposed budget. So while there was an increase in fiscal 23 across these three programs, there was a slight decrease in the budget. So according to data provided by the Department of Aging in the first half of fiscal 2023, all three of these programs have actually seen increases in their wait lists and decreases in the number of people participating in the programs. The most dramatic change is in senior care, which is also the largest program offered by all three of the local area agencies on aging, or the local AAAs. And so looking specifically at recent data for senior care and SALS, we can see that since fiscal 2019, the waitlist as a proportion of people served has been decreasing, but still remains high in senior care, above 80%. And then in SALS, that proportion has been increasing slightly, ending at 69% in fiscal 2022. Exhibit 9 on page 15 shows this same data, but broken out by jurisdiction. And so in nearly every local AAA, the waitlists have actually increased during this the first 6 months of fiscal 2023, except Upper Shore Aging, which cleared its waitlist of 12 people during this time. And so all of this data has just been noted by DLS because these programs have also received cuts in their funding while maintaining pretty high wait lists. I'm going to turn now to the second issue that we're bringing up quickly, which has to do with federal stimulus funding. The Department of Aging has been awarded a total of $48.7 million through COVID-19 federal stimulus legislation. Exhibit 10 on page 17 shows the awards by legislation. Like I said earlier, CRSA, the Coronavirus Response Relief Supplemental Appropriation, and the American Rescue Plan Act funding are two of the only current funding that the department is spending down. They allocate this money to the local AAAs, which then use it for their programming. Exhibit 11 shows CRSA expenditures by local jurisdiction. This is the funding that expires September 2023, the end of the federal fiscal year 2023. And so most of the jurisdictions have spent a majority of their funding, besides Montgomery County and Baltimore City, which also received the largest allocation. And the department reported that it's likely that these jurisdictions are prioritizing other funding sources. So I'll conclude with DLS's two recommendations. The first is related to the waitlist data that I spoke of earlier. We're recommending that the committee adopt narrative requesting an update on program participation and waitlists for senior care, SALS, and CHSP. And then the second recommendation is to adopt a narrative requesting an update on the federal stimulus funding, making sure that local AAAs are on track to spend that down ahead of the expiration. And that concludes my presentation.
Thank you, Ms. Camaro. At this time, I'd like to bring up Madam Secretary. And I'll start with, as we got history, it is also great to see the acting come off.
Thank you so much.
Yes, ma'am.
Let's make sure this can actually help. So good afternoon. And I have to say, I
I learned an awful lot hearing the other reports and the responses. So that was well worth the time for me. So thank you. I know you all would like us to hurry it up here, and we will. I am Carmel Roque. I am the Maryland Secretary on Aging, and with me I have some of my key staff. To my right here is Bernice Hutchinson, Deputy Secretary, and to my left is our CFO, Linda Weaver, and beside her, Chief of Staff, Pamela Seidel. I also want to recognize, and you all are still here, the Area Agency on Aging Directors, because they are very much part of our department in that the funds that we receive go primarily to the local jurisdictions, and without them, there would be no services to older people in Maryland. So I will call out Patricia McGee from Montgomery, and you all can stand up. Ophelia Ross Ott, Howard County, Karen Sylvester, Prince George's, Laura Riley, Baltimore, Lori Jennings Harris, St. Mary's, Dina Barclay and Lisa Furlow from Charles County, Erin Bird, Cecil County, Carolyn True, Frederick, Karen Winkowski, Hartford, Carissa Kelly, Anne Arundel, and Andy Hollis from the Upper Shore. It is so gratifying to me personally in my role as Secretary of Aging to see the support and engagement from our AAAs. All of you know that the Department on Aging is here to ensure the well-being of older people in Maryland, their families, and their care networks. You've heard from the report and from the analysts report that was given that this is something that we are struggling with. And I want to thank our analyst for her great work looking at our department and working with our department on understanding areas for improvement and the challenges that we face. I'll just go to the two most important things that I have in front of me. And I think this is my 36th day as secretary. The first one has to do with rebuilding the department. With a 25% vacancy rate, it doesn't take a lot of imagination to understand that we have struggled to meet not only our statutory requirements, but to be able to move into the area of advocacy, policy making, recommendations, all of those additional things besides the statutory requirements of receiving funding from the federal government and the state and ensuring that it's properly dispersed to the AAAs. So we are working hard on this issue of being able to become a department that actually individuals seek to become a part of, because we are doing such exciting and wonderful work under the Moore Miller administration, ensuring that no older person is left behind in Maryland. And we have a pretty specific set of activities we have proposed, but most importantly, we're beginning to receive the additional support that we need from the enterprise group that really serves as our HR and tech support. And we're beginning to be able to move more quickly because of some of the things that the governor has made possible for us. The other has to do with expenditure of funds. One of the challenges that the department has had, partially because of limited staffing, both at the level of the state MDOA, but also with the AAAs experiencing similar staffing difficulties, is being able to disperse that funding appropriately and in the timeframes that have been provided. Some of that is because the AAAs have other sources of funding that had even more stringent timeframes, and so they spent those funds first and are now getting to the remaining funds. We have funding that I'm working on finding ways to disperse in an equitable fashion that are COVID funds for workforce development. And We have a new employee who will be starting with our department in the next weeks, who will be taking that project on. There are also some very specific issues with the SALS funding that relate also to the wait list that I want to address. When the department really looked into this, and spoke with our AAA directors and engaged them in this conversation, it became clear that there are guidelines about the way that money can be utilized that have impacted it being effectively and efficiently dispersed for the purposes it was planned for. And that we've encountered at the local level that providers of assisted living services have been unwilling to engage with the local AAAs and the department because the funding subsidy is not enough to attract them to the program. So we have as a project in front of us, and we've just formed the work group on this, to look at the legislation that created the SALS program and to make some tweaks to that, and to also be able to make recommendations around increased funding so that the cap of $1,000 could possibly be addressed. Those are the items that I really wanted to quickly respond to. And I also want to let you know that we've already begun to put in motion the opportunity that the department has to involve the state in a stakeholder engagement process that will allow us to begin to look at centering older people and their families and their provider network in all of the work of government. So for older people to truly thrive in Maryland, they need to be have housing that is affordable. They need to have food security. They need to have equitable access to healthcare. They need to have financial security. They need to have transportation. They need to be able to have clean air to breathe. And by itself, these are not things that the Department on Aging can bring about. But engaging with the other departments in the Moore Miller cabinet and with stakeholders across the state, both in government and outside of government, we believe that we will be able to begin to make progress in those areas. And so that is an area of the department where we're staffing up so that we'll have some additional capacity to begin to do that kind of work. That is probably the most critical thing in front of us right now. And the reason I say that is because longer lives, we're now at the 100-year lifespan. Longer lives is something that affects every aspect of life in Maryland. It isn't just about old people or people over the age of 60. We know that demographic is growing rapidly. It has an impact to across the lifespan, and finding ways that we address social drivers of health, for instance, that impact what life looks like at 65 for a person. We know now that the 5-year-olds of today, fully half of them will live to be 100. I checked the actuarial tables just to kind of see what it says about those of us who are 67 today, and I'm expected to live to be 94. That's a daunting prospect for many, many Marylanders because they do not have the financial resources to live out their later years comfortably and also connected to the larger social world and with purpose and meaning. And so that is something that this department is committed to addressing. And we hope that over the years, we will find ways to successfully engage stakeholders across the government and across Maryland in making Maryland one of the really best places to live and age. Thank you, and I will take any questions you might have for me. And if I don't have the answer, my troops will.
Thank you, Madam Secretary. I was trying my best to hear it, but it has been a long day. If you can just comment on page 8, there's for the recruitment efforts to take place to fill vacant positions and how the department plans to use the vacancy savings.
Well, I would like to say that once I drew to the attention of DBM that we needed additional human resource support, we don't have human resources actually as a pin in our own department. Once I made them aware of that, they were wonderful in stepping up and providing us with additional hours of support. What we're doing is we've mapped the agency and we've looked at where do we have open pins that can be repurposed? Where do we have open pins that need to be classified differently? And this is a really significant issue for the department, so that we can hire for people who will have the requisite skills and knowledge to do the work we need done. And it's sort of a all court press. The people here at this table know that this is a priority and are spending significant hours on that work. I think we will continue to have some outlier positions that are going to be difficult to fill, but we are looking at engaging with our HR resources at DBM to look outside of the sort of normal ways they recruit, and begin to do things like approach universities who have programs that might have students that are either matriculating or have residency or internship programs where we could scoop some of those people up rather immediately into some of those positions. So I think it's going to, you know, from my point of view, this can get much better, and it already has. I mean, we've already started hiring people simply because we have an administration that fully supports us being able to do that and has made some changes already that will make us better able to move forward with the hiring and onboarding process. I'll just say a really brief note about retention. I truly believe that that's an area where the culture that we build in the department will make all of the difference. And so under my leadership, the department will be one of collaboration, transparency, and kindness. And I think we're already seeing a difference, and we will continue working on that.
Yeah, thank you, Madam Secretary. If you could just send back, I don't need a comment, but like the one position that has been vacant for 26 months, what's the plan for that specific position? That would be helpful. Seeing no questions from my colleagues at the moment, just want to say thank you for your leadership. I know that a lot of the vacancies didn't happen under your tenure, but look forward to your leadership helping us course correct from that standpoint for one of our most important populations that's out there. Ms. Kamara, I say it and I say it again, just thank you for your comprehensive report. Colleagues, we have a number of folks that want to give public testimony for this specific agency and want to give them that opportunity. I'm going to start with my friend, Ms. Ann Seacott. Ms. Seacott, and if you. If it's possible to do it in 2 minutes.
Oh, much less. I'm Ann Seacott today representing M4A, the Maryland Association of the Area Agencies on Aging. This is the association of the 19 AAAs that provide the services directly to your constituents and people throughout the state. And we're here really to say thank you to the governor, to Secretary Roque. We're so excited to be able to work with the secretary. You heard in her testimony things, you don't know this, different than what she said in the House hearing. And that's just been a week's worth of work that she's been able to accomplish. We are so excited about working with her team on making sure that we're addressing the greatest needs of low-income older adults in Maryland. And we think that we're going to actually be able to be partners in finding a lot of solutions. So we're here to say thank you and good luck and all that good stuff.
Thank you, Ms. Seacott. And at this time, I'd like to bring up Ms. Reagan Vaughn from Catholic Charities of Baltimore.
Mr. Chair and members of the committee, my name is Regan Vaughn. I'm the Director of Advocacy for Catholic Charities of Baltimore. I wanted to talk a little bit about the congregate housing program, which is seeing a cut in the budget. Catholic Charities operates a nursing home, an assisted living, an adult daycare, and then 24 senior communities. And that balance reflects our experience that seniors want to age in the community and would prefer to be in apartment buildings than in institutional or medical care. At 6 of those communities, we offer the Congregate Housing Services Program, which provides meals, laundry, and light housekeeping to seniors who are living in the building on a sliding scale with a subsidy from the state. And by meeting those needs of the seniors, we're able to keep them in the building and delay their entry into a higher level of care. The cost to the state is a few $1,000s a year per person, which is a lot cheaper than a nursing home. I think you're going to hear a testimony about that after me. But the Congregate Housing Service Program isn't without its issues. The regulations we don't think have changed since it was founded in the 90s. And funding has always been really tight. And so if we want to improve our basket of services or deal with inflation, the cost has normally been borne by the residents when the state doesn't increase funding at those times. And so we were really disappointed to see that in this budget, there is a 12% cut to the program, or $272,000, because another program stopped offering congregate housing services. And instead of redistributing that funding to the existing buildings, it was cut from the program already. And so we know that you have some new powers this year, and the department didn't necessarily get to see this before the budget went in. But if there's any way to save that funding for congregate housing, we'd like to see it level funded. I also, just a quick note on the wait lists. The congregate housing wait list only includes buildings that have the program. So Everett Gardens in District 45, or Owings Mills Newtown in St. Charles in District 11, who don't have the program. If residents there want congregate housing services, there's no way for them to even get on a wait list. So I think the wait list numbers severely undercount the need for this program, or the way the program could be used in different buildings. And we look forward to working with the department in the future on improving the program and hopefully expanding it to new buildings. And with that, I will stop and thank the committee.
Ms. Vaughn, thank you. And seeing no questions from my colleagues, we'll bring up the next person, which is Carol Leinhardt.
Good afternoon. My name is Carol Leinhardt, and I am the retired director of the Harford County Office on Aging, an alumna of the Baltimore County Department of Aging, the current co-chair of the Maryland Senior Citizens Action Network, which is MSCAN for short, and also a past president of the Maryland Association of Area Agencies on Aging. And first of all, I'd like to join everybody else who has spoken in commending the local area agencies on aging, because it is they who deliver the comprehensive services to Maryland's 1.4 million seniors. And I'd like to just you have my written testimony, and I'm going to be merciful in that I'm not going to read it. Just like to cover a few points. And I think it's kind of sad that when people look at expenditures for social programs, they generally only look at what it costs and not necessarily the impact. And the Department of Aging, as you know, have numerous programs, And they are all designed to save money for the taxpayers. I'd like to just cite a couple of those programs. The senior care we've heard a bit about, and currently there's an average waiting list of 2,100 seniors. And every year, on average, 150 of those seniors go to nursing homes before they ever have an opportunity to get senior care services. And what happens is, this is very bad news for the taxpayers, because to institutionalize those 150 seniors cost the state over $16 million. And a package of services for senior care is about an average of $7,000, which actually is $2,000 less than it costs to put some one person in a nursing home for 1 month. We can serve senior care clients for $7,000. And if we could spend that or look at that $16 million, we could serve the entire senior care waiting list for about 14 million and still save the taxpayers $2 million. And I'd like to take a look at the Congregate Housing Services Program, which was just mentioned. It costs about $3,000 a year to serve one Congregate Housing Services Program. And I visited those programs, and to see how happy the people are to be able to stay in their own apartments, it's just a beautiful thing. But as we talked, it costs one person in a nursing home for 1 month, $3,000 a year for one Congregate Housing Services client. So that means we could serve 3 clients for a whole year for what it costs to put one person in a nursing home, $9,000. So I think you can see that not only are these programs a good use of money, they're actually an investment. They save money, but you invest money. And I think that's a good thing that taxpayers will love. And with these examples, I think that it does help you to see what a great investment it is for the Maryland Department of Aging. And I thank you very much for the opportunity to come and testify about these programs.
Thank you. And last, colleagues, we do have Mr. Eric C. Coming up for the Alzheimer's Association. I just don't want to butcher it.
It's all good. Chair McCray, members of the committee, Eric Colchimuro, Alzheimer's Association. Thank you for the opportunity to testify. Thank you to Secretary Roque. We at the Alzheimer's Association are thrilled to have a now officially Secretary of Aging with experience in senior and aging issues. Full stop. As we move forward, and in the spirit of the Moore Miller administration of not leaving anyone behind, and the inaugural about choices, I think I'd just like to take the remaining time of my testimony to offer 3 choices. And as the governor has said, we don't necessarily have to choose between them. We can choose to do both. So one choice, can we both equitably fund area agencies on aging, acknowledging population differences and the certain costs that are higher in rural communities? Another choice, can the Department of Aging work across agencies, elevating the quality of care in our long-term care facilities, recognizing that the industry has been disproportionately affected by COVID-19, and acknowledge both the budgetary needs of providers and consider how the agency might work to increase worker wages, especially of the direct care workforce who has provided and continues to provide such essential work. And lastly, can we look at the Maryland Department of Aging's programs and consider the senior care program, which we've heard so much about today, which works, which allows people to age in place on average from what we've heard 4 to 7 years longer than non-recipients, and consider the path forward for initiatives started under the last administration, evaluating whether they're an effective use of taxpayer dollars. There are big choices that come with the next administration, 30 plus days in. We're excited to continue to partner with the Maryland Department of Aging, be a force multiplier for their initiatives, and thrilled by the selection of Secretary Roque to lead the department. Thank you for the opportunity.
And thank you. Seeing no further questions from any of my colleagues, I think that we all go on and sing your accolades, Secretary Roque. But just want to say thank you all for everyone that attended. This does end the budget hearings, and this is our last budget hearing, colleagues. So look forward to budget decisions at some point in time. You all have a blessed day.